Good afternoon, ladies and gentlemen, and thank you for waiting. Welcome to the VHQC Medication Management Regulation and Resident-Centered Care Call. All lines have been placed on listen-only mode, and the floor will be open for your questions and comments following the presentation. Without further ado, it is my pleasure to turn the floor over to your host, Ms. Eileen Bennett. Ms. Bennett, the floor is yours.
Thank you so much, and welcome to everyone who's on the phone and for having an open mind as we move forward in our journey of culture change. We are definitely, if you want to bring up the first slide, Maryland Culture Change Coalition is co-sponsoring this event with several of our partners. We are doing this under a grant with the Maryland Office of Healthcare Quality in promoting culture change under our Culture Change Coalition. The slide actually indicates primarily what our focus and goals are of the Culture Change Coalition, but I'll be honest with you, it's common sense approach to person-centered care. So I'm going to invite you to become an active participant, not only in this webinar, but also in our monthly meetings, our abilities to get together, and our future training. I would like to announce that we will be having an in-person conference on June 3rd, and so we hope that you will have the opportunity to join us in person. I'm happy to also indicate that we have people from the Virginia Culture Change Coalition joining us, and I'm going to turn this over to Sonia Barnett and welcome her into our joint effort here.
Thank you so much, Eileen. Hi, everybody. This is Sonia Barnett, and I am fortunate today to be representing the Virginia Culture Change Coalition. We actually have been in existence since 2002, but over the last few years have been a little bit quieter as an all-volunteer coalition and are now ready to reignite the coalition in Virginia and to continue the good work of promoting culture change throughout the Commonwealth. So I'm really glad for this opportunity to share with everyone that there is a Virginia Culture Change Coalition, that we would like all of you to be involved, that we really are looking forward to new things that we would like to bring to all of you throughout Virginia. So on the screen here I have our website as well as my contact information, and I would just like to ask you all to consider becoming involved or to sign up just for information on the website from the coalition so that we can contact you as we develop things such as educational programs, and to really give us your feedback as to what you see as the needs, as your needs in promoting culture change throughout the continuum in Virginia. So thank you for this opportunity, and I look forward to meeting and talking to many of you, and I will hand this back to Linda. Thank you.
Thank you, Eileen and Sonia. Good afternoon, everyone, and welcome to our webinar. My name is Linda Harris, and I am an improvement consultant with VHQC. VHQC is a private, nonprofit healthcare consulting company that has served as the QIO for the state of Virginia for over 30 years. Currently, we serve as the Quality Innovation Network Quality Improvement Organization, or the QIN-QIO, for Maryland and Virginia. VHQC consultants come from a wide range of healthcare backgrounds. Our experienced team includes former hospital executives, nursing home administrators, physician practice managers, nurses, health information managers, health communicators, physicians, and pharmacists. The overall goals of the Nursing Home Improvement Network are to decrease antipsychotic medication use, decrease potentially avoidable hospitalizations, increase mobility of long-stay residents, improve quality measures, and system-level improvement such as staff stability and consistent assignment. The VHQC online community provides a 24/7 location for you to engage with other nursing home providers in the network with VHQC improvement consultants, expert faculty, and peer mentors. We encourage you to join today and take advantage of this additional resource offered by VHQC. Contact information for the nursing home consultants is shown on this slide. Please feel free to contact us if you have questions about the network or are interested in becoming a participating provider. Please note that this webinar has been approved for one lab block hour and one Category 1 continuing education for social workers licensed in Maryland. Please be sure that you complete the evaluation that will appear on the right side of your webinar screen at the conclusion of the presentation. Now, it is my pleasure to present the speakers for today, Bill Vaughn and Jennifer Hardesty. Welcome, Bill and Jennifer. I will now turn the webinar over to you.
Linda, thank you very much. Welcome, everyone. We're really glad to be here. This is obviously Bill Vaughn. I'm sitting here with my colleague Jennifer Hardesty in Baltimore. And as appropriate, ladies should go first. So, Jen, please tell us a bit about yourself.
Thank you, Bill. Good afternoon, everyone. As Bill stated, my name is Jen Hardesty. I am currently the Chief Clinical Officer and Corporate Compliance Officer for Remedy, but I am a pharmacist by training. So I spent many years as a consultant pharmacist in the field consulting for nursing homes and assisted livings. And now for Remedy Senior Care, we're a long-term care pharmacy. We head up the clinical services and consultant pharmacist team that we have in charge of managing that team and thinking of new and different innovative clinical programs that we can roll out to our customers. So I'll be speaking more for the second half of the program today. I'm going to turn it back over to Bill to introduce himself a little further, and he's going to carry us off for the first piece of this program.
Thank you, Jen. So, everyone, my name is Bill Vaughn. I'm a nurse. I've been a nurse for over 30 years. I know many of you on this line from my previous job with the Office of Healthcare Quality. I was a surveyor in Maryland from the late 80s to about 2001. And I was the chief nurse of the Office of Healthcare Quality in Maryland from 2001 until 2013, where I had the pleasure of joining Remedy Senior Care. So it is my pleasure to work with Jen and providing you with a really important topic. I want to highlight something that Eileen said in her introductions. She used the term common sense when it came to culture change. One of my goals for my portion of this talk is to look at regulations from a common sense standpoint as it relates to medication management and culture change and resident rights. And I think if we look at it that way, we're all going to be pretty successful. So during this webinar, if you have questions, please type them into the chat box. Our colleagues will review them, and if appropriate, go ahead and interrupt us during our discussion. At the end of the webinar, we anticipate having about 10 minutes for open discussion, so you can hold your questions to then as well. Obviously, the topic of medication management generally, without exception, touches every resident in a nursing home. And it's one of the more critical pieces of their care. And we're going to take a look at it from the standpoint, again, first from a kind of a regulatory rights standpoint, and then Jen's going to follow up with really very important geriatric principles of medication management. So facilities are going to be in a good position to inform residents of what's important and maybe what's not important when it comes to managing their meds. There's Jennifer, disclosure is on the board. I do want to just highlight one piece under my disclosure. Since we're talking about medications, I am part of the Institute for Safe Medication Practices Clinical Advisory Board. ISMP, as many of you know, is a nonprofit out of Pennsylvania that does really nothing but look at medication management and has an incredible database that looks at medication problems across the continuum of healthcare. Over the past year and a half, they've put out a long-term care newsletter every month, which is free to facilities. So if you're not receiving it, it's very easy. Go Google ISNP. That'll get you to their website, and you can sign up for it for free. It is really very helpful. It will share with you some mistakes your colleagues may have made and prevent you from making them as well. And obviously, after the webinar, if you need to contact Jen or I, we have our contact information there as well. Our learning objectives are on the page. I'm not going to go over them. So we're going to talk about regulations. So let's just start at the beginning. Why should government regulate nursing homes? And I know I'm preaching to the choir. Nursing homes are very heavily regulated. There's good reason to regulate nursing homes. Government has an interest in protecting vulnerable people, and you don't get much more vulnerable than being an elderly female with advanced dementia in a fetal position in a nursing home. So there's certainly reasons for government to protect vulnerable people, but perhaps in the same vein, there's reason to account for the money that's spent on nursing homes. So nothing is ever as pure as like protecting the vulnerable. But I've highlighted the term nursing home on this slide. The term nursing is key because, quite frankly, nursing homes are, with all due respect to my colleagues, run by nurses. They're there 24 hours a day. They are the one closest to the patient. And much of what we're going to talk about today looks at the role of the nurse in helping residents manage their medications well. After being in regulations for a long time, I think I've been able to boil down what all those federal regulations say about nursing homes into these really 8 bullet points. So under quality of care, no matter what tag you look at, it basically says this to me. If you get a resident into your nursing home and you can make them better, do so and potentially send them home. If you have someone admitted and you can't make them better, do all you can to keep them stable. And certainly when you talk about medication management, there's a large play there. If you can't keep people stable, the regs charge you to slow their decline. And lastly, under quality of care, the regs say you shouldn't do things that hurt people that are avoidable, like medication errors or failing to turn and reposition somebody and allowing them to develop bed sores, or doing something as simple as giving somebody who's allergic to shellfish shrimp salad for lunch. So at the end of the day, all those regs mean those 4 things to me. On the quality of care side, which is really what we're going to focus on, the regs say key involved. The me is the resident, and unless they lack capacity, the surrogate decision maker. And this next one's an important one. The regs really empower residents to make choices, and facilities need to let go and make sure they're comfortable in letting residents make good and quote-unquote bad decisions, because it's ultimately the resident's decision on how their time in the nursing home goes. And I know that in a heavily regulated environment, some nursing homes fear getting in trouble with regulators when residents make bad choices. I don't believe that's the case at all. I think the role of nursing homes is to present the risk and benefit of related to resident choices, and then actually support the choices residents make, obviously within reason. Remembering that you're a partner to residents, not their parent, not their overseer. And lastly, I think the regs charge you with trying to keep people as a person who's lived a life, not as a nursing home resident, but as a mother, a daughter, a father, a business person, and not look at them as patients. So at the end of the day, all that big orange red book that you guys have just boiled down to those 8 bullet points in my mind. I do want to briefly talk about what happens when the federal government decides something as a regulatory priority and how that changes behavior. So I've listed some stuff out on this slide. In the upper left-hand corner is a restraint. So 30 years ago when I walked into a nursing home, it would not at all be uncommon to see someone in bed in a cozy vest, not for malicious or unwarranted reasons. It was to protect them, quote unquote, but it was extremely common. And the federal government really did the full court press in looking at restraints and dramatically changed behaviors of providers, whereas it would be an absolute aberration to walk into a nursing home today and find a restraint. If you look down one picture, you'll see a bed with side rails up. So when I was in nursing school back in 1982, if I had left a resident in bed without putting the side rails up, I would have failed the class. Today, if you're in nursing school and put the side rails up without a good reason, you fail the class. So there's an evolution of standards, and the other stuff, depression found to be significantly underassessed and undertreated in the elderly, a big push for that. And then common ones like acute prevention, falls, and pain. So when the government picks a topic through their regulatory arm, and I hope to some degree their educational arm, they can really make a difference with the level of care that's provided. And there is exactly that going on right now in nursing homes. So there is a memo that came out from CMS in July of this year. I'm not going to read this stuff to you. The bottom line to this is a couple things happened. There was an OIG report in February 2014 that looked at the first couple weeks of care in newly admitted residents and found a significant number had adverse events, and a significant number of those adverse events had to do with medications. And on top of that, there was a really rather well-publicized Washington Post article in July of this year, which talked again about probably one of the highest drugs that anybody uses, and that's Coumadin, and the number of deaths that occurred between hospitalized and nursing home residents due to Coumadin errors. I would argue that the number that's listed in the article, in my experience, may even be low. But it highlighted the potential risk associated with medication use. And because of that, CMS is making this yet another priority. They started piloting focus surveys on medication management during the pilot phase, but I would not be at all surprised for this to permanently join the list of focus surveys now, which includes MDS, dementia care, and other things. So medication management is, and I think appropriately should be, a regulatory priority. So let's talk about where the involvement of residents comes when we talk about medications. I've listed out F-154, which is a federal tag for nursing homes. These are refreshingly clear regulations compared to many other regulations. It really talks about what resident has in terms of rights when it comes to their health care, and it's really rather broad and specific about what rights they have. And when residents have rights in a nursing home, it's typically the nursing home's duty to fulfill those rights, and it certainly is in the case of medication. So residents have a right to be fully informed, important in a language that they can understand about their total health care and including their medical condition. I don't think anybody would argue that that includes active discussion with residents about medications, taking them, not taking them, and expected outcomes. Important to note with the same reg is these discussions about medication use have to occur before you start using them, not afterwards. What does informed consent look like in the real world? It's not, I Googled or searched the federal regs. I did not find a definition of informed consent, but I'll give you my view on it. I think when medications are used in geriatrics, and actually I think this is across the board, if you're going to start a drug, at a minimum, you have to tell a resident or the surrogate decision maker why you want to start the drug. What is it you expect to do? Does the resident have an infection that you're trying to clear? Does the resident have a condition such as atrial fib that may cause them to throw a clot and have a stroke? What is the purpose of the med, and what is your expected outcome? Then I think providers have to talk to the surrogate or the resident about common risk. You know, when all of us look at the drugs we take, if we were to look at the package insert, it's not reasonable, I believe, to assume that every risk has to be discussed with residents. But the common ones, and maybe more importantly, the higher risk ones, should be discussed. And I think the third term of informed consent is giving the surrogate or resident a chance to discuss their concerns with you. And how much is enough? The regs don't say it, but I think if facilities took that approach, those three prongs, I think most of the time they would do fine with regulators, and also add to resident empowerment when it came to medication management. Of course, in the best of all worlds, that conversation, that discussion, if it's reduced to 1 or 2 lines in the medical record, will save you probably lots of discussions with surveyors when that issue comes up. How much information is enough? Again, I think that's not clear-cut. Certainly, if you're going to start somebody on Coumadin and you don't discuss the risk of bleeding, that's problematic. And so, again, the devil's in the details. I think you have to look at each and every situation. Here's a great example. So antipsychotic use for dementia-related behavior and long-term care has been in the spotlight for many years now. And to me, this is all about the risk and benefits of using this drug. So I would think at a minimum, if a facility wanted to start an antipsychotic on a resident specifically to treat dementia-related behaviors, they would have to say to a resident, here's what we want to do. We want to give you this drug to reduce concerning behaviors that are potentially harmful to you and are really disrupting your quality of life. Now, of course, it goes without saying that there should be lots of other interventions before we go to drugs, but if we're going to go to a drug, they ought to talk about the expected benefits of this drug and how long they're expected and what kind of things we expect to see. But on the risk side, so I think the evidence is pretty clear. There's a black box warning for atypical antipsychotics used for this condition, that your risk of death goes up significantly after taking them. I wonder how often nursing homes have this discussion with with families and residents and surrogates when this drug is given. I wonder how many people would say, it's okay, I will take the drug even though I know my risk of death goes up. Perhaps it does go on, I'm sure it does go on to some degree. But this is an example of the kind of discussion I think the reg is trying to get at. Here's a question, it's a theoretical question because you can't really answer it. One of the most common forms of consent in a nursing home happens every year. Happens every fall when nursing homes roll out their influenza vaccine. And almost without exception, every nursing home has the residents or their surrogates sign a consent form that lists out the risks and benefits. Would you say that signing that consent form meets the intention of this reg? I'll answer for you. I don't think it necessarily does, because this reg requires, again, full information, and we don't know by reading that consent form whether or not the resident can really understand it. So I advise facilities that there needs to be more to consent than simply signing a form, and I think that's pretty much the standard. Let me just talk real briefly about the next thing on the horizon when it comes to medications. Again, in terms of looking at risk and benefits, anybody in long-term care has heard over the last 6 to 9 months the evolving focus on antibiotics. So statistics from CDC and the studies they've relied on indicates that antibiotics are one of the most common group of drugs given to nursing home residents, and up to 75% of people who receive antibiotics in nursing homes either should not receive them, they don't have enough evidence to treat an infection, or the actual drug choice is wrong, duration is wrong, dose are wrong, or is monitored incorrectly. So you've all seen proposed regs from CMS on antibiotic stewardship and on infection control. I don't think you need to wait to act on this kind of information. I think the 4 bullet points I have in red here basically talk about a reg that already is in existence, and that's F329. So I think facilities now should be, for the residents' sake and for the facility's own regulatory sake, looking critically at their antibiotic use. Real quickly, I was taught that elderly people don't localize infections well. So when someone has a change in mental status, it was perfectly reasonable to get a urine culture, and if urine culture was abnormal significantly, to attribute that change in mental status to a urinary tract infection. That thinking has clearly changed, and it's clearly changed in that unless the resident localizes signs to their urinary tract, I think the current thinking is not to attribute their clinical changes to a urinary tract infection. I believe this is going to get really critically looked at in the very near future. So I do want to share some deficiency data with you very quickly. If you look at the first 10 months of 2015, this is the total number of times F-154 has been cited, 200 times across the country, 0 deficiencies in Maryland and Virginia. So that either means the nursing homes here are doing an exceptional job of getting and obtaining informed consent, or excuse me, that haven't quite become a regulatory priority yet. Informed refusal, so I'm going to go to 155 very quickly. It is an absolute right for residents to refuse treatment and to formulate and grant directives which in it refuses treatment. Very clearly guidance to surveyors. If someone says no and the nursing home provides care, that can be extremely problematic from a number of standpoints. If a resident says no to proposed treatment, that is not in and of itself grounds to discharge them. And also, if a resident says no to treatment, let's say a resident doesn't want to be treated for a particular infection because they understand that if you give somebody antibiotics, the risk of C. diff goes up. The facility still has an absolute obligation to perhaps hydrate aggressively and do other measures that may minimize the significance of that infection. So no means no, but it doesn't alleviate the facility from still doing what they can to address the issue. I just took this because noncompliance is typically a negative word in a nursing home. We view noncompliant residents as not doing something they should be. This is just a brief quote from a doctor who wrote in the New York Times about her grandmother who never took the drugs the way the doctor instructed her to do, and eventually had a very bad heart attack and died suddenly from it. In retrospect, the doctor said that the resident's refusal to fully comply with her medication management may have prevented her long-term demise in a fashion the resident didn't want. So my takeaway is noncompliance is in the eye of the beholder. The fact that someone doesn't choose to take one of our recommendations is not necessarily a bad thing. Informed refusal, again, end-of-life care is where we see this a lot. Risk-benefit changes the closer we get to end-of-life care. I think from a takeaway point, the use of antibiotics in advanced dementia is certainly permitted. Whether or not it's always appropriate to treat a cause that's not going to affect the underlying condition is really a resident-centered decision. Pain and symptom management, again, how much opioids are you willing to take to get comfortable versus getting some potential side effects. All this stuff is well-known risk and benefits, and I often advise people, if they're going to do an advance directive, to have these kind of discussions with their power of attorneys to be aware of their feelings on it. This one's going to be quick. There's a reg that says you can self-administer drugs provided the facility thinks you can do it safely. The resident-driven med pass. So we just talked about the decision to accept or refuse meds. If meds are accepted, there's a whole dance facility to go to in getting the medication from the pharmacy into the resident, and that's the resident medication pass. Iconic in a nursing home, requires a lot of resources. It's a big nursing practice issue. This is a reg about self-determination, and it talks about things like residents having a right to choose schedules and when they get things are important to them, and making choices about their life that are important. And I will tell you that perhaps getting woken up at 5 a.m. to receive a drug may be the best possible practice for the drug, but it may not fit in well with the residents' quality of life needs. And so there are no absolutes, and I think this reg does give residents a right to, within reason, impact how their drugs are given. Jen's going to go into a much deeper dive with this. The resident-driven medication pass does all the kind of things we look for in resident-centered care, offers flexibility, limits the institutional footprint. It makes facilities look at why we do things, and sometimes that is not always what we would expect. As a nurse, I know we do a lot of things that I was taught 30 years ago that may not be as important today. So I'm going to let Jim really talk about it. But my last bullet point here under this was, in terms of resident-driven medication, certainly plans for impromptu LOAs, not having meds available shouldn't limit a resident's ability to come and go in a nursing home. The resident-driven med pass has its own risk and benefits, but it's certainly, as you can see, consistent with federal regulations. My final thoughts are, if facilities did these three things in all the care they provided, they based it on good evidence, they looked at a critical look at risk and benefit, and always involved resident and surrogate decision makers, that they would stay out of trouble with regulators, but much more importantly, really improve the quality of care and quality of life for their nursing home residents. So with that, I'm going to hand this over to my colleague Jim to talk a deeper dive into geriatric principles of medication management. Thank you all.
Okay, thanks, Bill. So for the next section of this presentation, I'm going to talk and focus mostly on medication management and medication paths. We're going to start with basic geriatric principles. We just heard from Bill about the resident-centered med path, and I think what we've done over the years is made the med path easy for us as operators, easy for temporary nurses to step in, or contract agency people, easy for us to monitor, but it's not necessarily the best for the patient. So by following some basic geriatric principles, I think you'll see as we go through this, there is more flexibility than what we currently, in most cases, are doing, but you do have to be smart and think about it. It takes a lot more thought and effort to create a resident-centered med path rather than just kind of the big machine I think that many of us are used to doing. So we'll talk about the basic principles. We'll talk about some medication timing issues that are a reality that we do have to face and things that you need to look at as you are determining if you want to create a resident-centered med path in your facility. And then finally, some other practical tools that you can use to help create a resident-centered program for med management. On one of the previous slides, Bill did have listed a very comprehensive aspects of medication management in a resident-centered process, and you can pick and choose pieces of that. You don't have to go necessarily whole hog, for lack of better words, on a resident-centered med path. You can pick and choose pieces that will improve resident quality of life, but may be easy to incorporate in your current med path system. So we'll talk about a couple of those as well. So getting started on some basic geriatric medication management principles. The first one listed here is something if you work in long-term care or with the senior population is obvious, but our patients have a lot of chronic diseases and they are multifactorial and in many cases very advanced. So that actually makes it a challenge for us to pick the right drugs at the right dose with the right monitoring and the right frequency. It's kind of a bit of a puzzle. So we really can't make sweeping changes with these patients. We have to really be thoughtful about the changes we do make to their medication management therapies. We do have a lot of conditions in our patients that are in many cases underdiagnosed and undertreated. Bill mentioned depression was an initiative probably about 5 or 10 years ago. We really found it was underdiagnosed and undertreated in our population, and we really changed the tide for that, but that is certainly always an issue we have to deal with. There are a lot of iatrogenic illnesses, and that's just kind of a fancy word for illnesses that are caused by external factors. So it's not the patient's body that's causing a problem. It's things like alcohol, smoking, or even prescription drugs that can actually cause syndromes and other bad events, adverse drug reactions, that we're causing in our patients. And there's a lot of that going on, and we'll see a focus on that from a regulatory perspective here, as Bill mentioned, with some of these focus surveys. And they can often cause what we call prescribing cascades. So a patient takes an antibiotic, they get an upset stomach, they get put on a proton pump inhibitor for their upset stomach, and then that causes them to have diarrhea, and then they get a med for the diarrhea, etc. So in some cases, because we're not being very thoughtful about the meds we're choosing, we're actually causing more problems with drugs than sometimes we're solving. Of course, with our population, and really a central aspect of person-centered care, is that it's not necessarily the medical goal we're trying to reach, like a lab value or a number. It's really determining the best way to get to functional ability and quality of life for these patients. So what may work for instance, for diabetes treatment in a younger patient may not be so applicable in our patients, really looking and focusing on quality of life and how do we get there with the tools that we have. And then my final basic principle that I see in practice a lot, but I think we'll be seeing even more in the future, is the multidisciplinary aspects of geriatric care. And this is really where I put my pitch in for pharmacists, because we do have pharmacists in long-term care, but they're kind of like high flyers. They come in many times and are there once or twice a month. And I think with the complexity of the patients we're seeing, we really need a larger presence of pharmacists in the building with the physicians, nurses, dietitians, and social workers that are there, because the medication management is a really critical piece that can make or break a patient's quality of life and potential recovery. So here's another basic principle. This has been around for a while, but this is a mantra that all students of geriatrics are likely taught, which is talking about medications and starting medications, starting low, meaning a low dose, and go slow, meaning start with a low dose of a medication and slowly titrate up so you can make sure that your patient is doing well and that they're responding well. But then the second piece of this, which is make sure you do still go, meaning don't get stuck on a very low dose and titrate up because you're fearful of potential adverse events and the patient ends up not really getting well treated for their disease. So again, starting low, going slow as we increase doses, also as we decrease doses. So as you look at taking patients off of meds, titrating them down slowly often for our more fragile patients is a better way to go. So just keeping this in mind as you're adding and taking away drugs can prevent some pain in many cases as far as adverse drug events. Now, CMS has an F-tag F329. Bill has mentioned it several times before. It is the unnecessary medication tag. And I don't necessarily bring it up because it's from CMS. I bring it up because I think it is really good, sound advice for evaluating medications. It covers the key aspects of medications, and as you're looking at your patients and their medications, trying to figure out, do you have the proper medication and are you managing it correctly? Because so many times meds are added, labs are drawn, and there's not a thought behind it. It's really kind of the big machine again. But really, if you look at this top section here in blue, this is the F-tag for unnecessary drugs. And if you really follow this principle, you will be able to tailor a medication therapy to a patient in the best possible way. So making sure that you've got the right dose for that patient, the duration is appropriate, they're not on meds that they could have been off months ago, that you're having adequate monitoring.
And just because a patient is on a med doesn't mean that you have to monitor everyone the same exact way with the same exact frequency. And this is a really important piece for the resident-centered care model. And the example that I'll give you is with insulin, for instance. We have patients that are on insulin, they're very stable, yet they may still be getting finger sticks 4 times a day. That is not, it's good for a patient that's unstable, but for a patient that's stable, is not having problems, and is eating well, there's no reason to go in and trick them 4 times a day, because you've seen, the past history over the past month or 2 they've been good. To continue that is actually, in my mind, creating, patient discomfort and almost patient harm. So being rational about why we're doing what we're doing, I think, is a really important part of person-centered care when it comes to monitoring these medications. Making sure that there's an adequate indication for every medication and that someone's taken the time to go through all these meds to make sure that the patient really does, in fact, need them. And making sure that if there is an adverse event going on, a side effect of some sort, that it's addressed and analyzed and that the patient is taken off the med if that's really what's causing it. And this is where, I talked about prescribing cascade a bit ago. This is where we really get into trouble with patients getting multiple unnecessary meds, because we're not really being thoughtful about what is the source of this adverse event, like a stomach ache or a bleed. Is it a medication? Is it something with their body that's changed? Sometimes we aren't very thoughtful about that. And then Bill touched on the antipsychotic piece, so I'm not really going to go into that. But again, I think it's very good basic information that CNS provides to us that patients that aren't on antipsychotics really shouldn't be started on antipsychotics until they really, really need them, and that risk versus benefit analysis has been done, and the patient and their family have been included in that discussion. I've also included here the F-tag for medication errors, because I think this is important. I know a lot of folks get concerned with medication pastimes, or when they're looking at really developing a resident-centered med path, am I going to get cited for a medication error because I didn't follow rule XYZ that I think most everyone else has followed? So an example of this would be Synthroid. For those of you that are familiar with it, it's typically given very early in the morning when you first wake up on an empty stomach. Because of this, patients that are on Synthroid, in many cases, are being woken up at 6:30 a.m. or 7 a.m. so they can get their Synthroid in the morning first thing. Well, if you really look at the manufacturer's specifications and recommendations, it's not really absolutely required. It's suggested. It may be best absorbed, but it's certainly not ineffective if you give it with breakfast or even with lunch. So in many cases, we have either urban myth or urban legend about certain medications. We continue to follow them because we're afraid that we'll, quote, get in trouble on survey or, get written up for a medication error, when really if you drill down on it, it's just a recommendation. And if you have a good reason not to follow it and the patient is stable, then there is no reason why you need to continue to wake up that person at 6:30 a.m. if they want to sleep in. So, again, looking into understanding what exactly was ordered by the physician, what do I have to absolutely do or else the med won't work, or what is just a potential recommendation from the manufacturer on these meds that I do have more flexibility with. Another piece I wanted to hit on is how the order is written. It's certainly important if you want flexibility in what time you administer a medication. So, for instance, if you have a prescriber writing, take Synthroid at 6:30 a.m., then you are pretty much bound to have to administer Synthroid at 6:30 a.m. But if your prescriber says, take Synthroid once a day, that's a much more flexible order that you would have the possibility of changing times and making things more flexible and realistic for that individual resident. So just even starting with how orders are written, as well as then how you implement that in your facility, whether it's an absolute time that has to be given or not, really gives you flexibility even in your current medication path system. If you're really rigid now, this would even give you some flexibility in your current system. So this is a picture of a very lovely nursing home, I believe in Virginia. But the reason I put this up is because nothing magical happens to patients when they leave home and they come into your nursing home. Medications certainly do not work magically better or worse, and your patients don't necessarily have to continue your practices compared to the practices that they were doing outside when they were living at home. So if the patient took their Synthroid at 9:30 a.m. after breakfast, after eating, there's really no reason they have to come into your facility and instantly now be awoken at 6:30 to take that medication. So just thinking about that patient and what they were like at home compared to what they are now going to have to deal with in your facility really puts it in perspective, and just knowing that nothing magical is happening with these meds, that they're suddenly changing how they work. They still work the same, and if they were working for the patient outside of the facility at that particular time, they will certainly work for that patient inside your facility as well. So if you're thinking about implementing a resident-centered MedPass program in your facility, there are some critical elements that you would really need to consider. And we've had some facilities that have moved towards this, and this is really the key areas that we identified that absolutely you must discuss within your facility and come up with some policies and procedures around. So the first step is really determining and developing the nomenclature that you want to use and the definitions of that nomenclature. So right now in what I call the standard MedPass, it's all driven by time, 9 a.m., 10 a.m., midnight, etc. But as you start looking at a more resident-centered MedPass, you want to make those MedPass times more flexible. So you come up with some of the terminology you see here, like upon rising, with lunch, and at bedtime. So really you have a window of time, not a specific hour of the day. Along those same lines, you will need to develop what once daily means in your facility, what twice daily means, what 3 times a day. These things you already do, but you do it with specific number times. You need to then translate that into some of these other more global times. The second piece that's really important is the clinical review of each resident's medication. So you really need to sit down, and this is probably the most difficult part for facilities because it does take an interdisciplinary team and it takes ongoing reevaluation of patients' medication regimens. So really it takes typically the physician, the nurse, and the pharmacist to sit down and talk about what's going on with this patient. And when you do that, you really do question the need for every single medication. There are a lot of medications out there that we are just continuing because they've been on them in the past, or because we're not even sure they came from the hospital on this medication. But to sit down and really think, does this patient need this at this point in time, is a very important discussion to have. Also, looking at what your goal is for that resident. Does every resident have to meet every single national guideline health goal? I don't think so. And I think in many cases, our goals in long-term care are much softer. And so we need to make sure that our medication management therapy is addressing that softer goal. And then finally, you need to look for specific contraindications for certain medications, because at the end of the day, there are medications that you really should not be flexible with because they will ultimately cause potential resident harm. So when you're doing this medication regimen review, there are a couple areas that we found specifically to be high-risk areas that really needed addressing. And as I mentioned, you can even do this now if you have a traditional, hourly-based med pass. You can do this now and clean up the medication path by just looking at some of these areas. So the first one is looking at any medication that is administered 3 times a day or greater. Because you're interrupting the patient 3 times a day, is there something else you could use that is not necessarily 3 times a day? Because, of course, it's more difficult to manage the timing of those meds. You can also look at patients that have less than 2 hours between consecutive med passes. So if you have a patient that's got a med pass at 12 noon and a patient that has the same patient has a med pass at 2, you would want to look at that and see, was that really necessary? Can we combine them? Can we figure out something else to do so that we're not interrupting that resident every 4 or 5 times a day to do med passes. You can also look when appropriate to convert to medications that have extended release formulations. So those meds that are given 3 or 4 times a day, do they make a once-a-day formulation, and then again, making sure it's financially covered by the insurance plan, et cetera. But can I switch to that, and that will decrease the burden of both the staff as well as the patient having to be interrupted for multiple med passes throughout the day. And then you do need to identify medications that have some aspect of critical timing, taken with food or taken on an empty stomach, and I'll give you a little bit more detail on those as we move along here. So when you're looking at a resident-directed med pass, there will likely be some exemptions, things that really you cannot be super flexible on time administrations with. And this is going to depend. It's really a moving target. There are some absolutes that I'll talk about, but in many cases, Things that we traditionally think, even antibiotics in some cases, that, well, I have to give it exactly every 6 hours. Well, maybe, maybe not, depends on the patient. If the patient is critically ill and they just came from the hospital, then, yeah, I think that would really require some precise timing. But if the patient is perhaps not as sick and they're on oral antibiotic once a day, perhaps that could be a little more flexible with a couple hours here and there, not really causing a clinical problem. So here's a list of potentially time-critical medications. So this actually came from some CMS guidance for acute care settings. But you'll see some of the traditional things here that you know are really time-sensitive. On this list, antibiotics, anticoagulants, immunosuppressants, etc. But what I've done here is just gone through and highlighted in red the ones that I think are particularly time-sensitive that you would need to have some kind of plan for, because ultimately they may cause resident harm if they're not timed properly. So things like insulin, the absolute timing of insulin doesn't necessarily matter, but what does matter is it in relation to food. So the timing in relation to food, if you don't do it properly, you can have a patient that will get hypoglycemic. Pain medications, especially those that are given around the clock, if you're late with those, the patient can experience pain, and of course that's not something we would want to happen. And Parkinson's medications is the same situation. Many patients, if they're in advanced Parkinson's and they miss their dose by 15 or 20 minutes, that can cause significant impact on their quality of life. So again, there are some meds that have a good bit of flexibility, but as you're looking across your facility, there are some that may not have quite that flexibility, and you would need to come up with a plan, whether it's educating the nursing staff or the patient, or probably both, really, about how you're going to manage that if you're looking at some resident-centered med pass times. Here's another example that we commonly see with medication errors, and we've seen surveyors cite this, and it's not necessarily something that should be cited, and this is with proton pump inhibitors. This is very similar to the Synthroid example that I gave earlier, where there's kind of an urban myth that they have to be given first thing early in the morning to be effective, and anything other than that is going to be deficient, and that's really not the case. What I have here is listed the different proton pump inhibitors for reflux, and you can see some of them are supposed to be given on an empty stomach for best effect. Some can be given without regard to meals. So in some cases, if you have patients that had maybe more evening reflux, then actually giving it to them before dinner might be more effective than waking them up at 6:30 a.m. to give them a PPI. So again, really knowing the facts and the details, understanding the patient's preferences and the patient's diseases and the different aspects of their disease will really guide you then to the most appropriate suggested timing for the meds. You can better understand some of the flexibility you may have. So when we look and try to do this with some facilities and focus on some more resident-centered med pass times, we've suggested that they identify some medications that they really want to focus on in their building because they're problematic. So this slide really shows what one facility chose to identify in their facility. So their facility has standard med pass times. It's not really a resident-focused med pass using a traditional institutional type of med pass. But they've looked at some of these meds that tend to be more problematic for patients, and they've come up with a better solution than what the standard med pass time is. So, for instance, the levothyroxine, or Synthroid, we talked about that a bit here, they have changed the med pass times to be with breakfast instead of waking everybody up super early in the morning. The warfarin they've changed to in the evening because they wanted patients to make sure that they were aware of what they were getting and that nurses were being very careful with what they were administering. They were looking at the Tylenol and cranberry caps and natural tears and seeing that they had patients on these meds, every 4, 6, 8 times a day. It was really kind of crazy what was happening. So they just looked at those and cut those back, working with a physician, so that patients aren't getting natural tears every 2 hours, and they're not having to take cranberry caps 4 times a day. So just coming up with some key drugs and working with your medical director and your nursing staff and your pharmacist, you can still use your basic institutional med pass process, but you're really looking at some of these drugs and shifting the times of them to make them more reasonable for the resident. So the next couple slides here really is talking about those key drugs that we've determined with the facility they wanted to attack and how they were going to attack them and kind of the clinical rationale behind it. So I really won't go into it much. I'll just give you a couple examples that we pulled out. Bisphosphonates, which are things like Fosamax or Boniva for osteoporosis. those medications, they really do have to be given first thing in the morning on an empty stomach with a glass of water. If you don't do that, then they just, quite frankly, don't work. And if you don't sit up, then they may give your patient some esophageal irritation. So there's really not a lot of flexibility in how you administer that, but there is flexibility in how often you have to administer it. There are weekly or even monthly dosings available. So looking at that, while we can't really change the time of day, we can say, well, guess what, we're only going to do it once a month instead of every day, and that will help the patient from that perspective. So some of these drugs, there are different ways you can attack the problem. For this facility, they had a lot of Senna and Senna S use, and the question became, do you really need it, first off? If it's multiple times a day, can we make it twice a day and just make it a bigger dose? Or can we even just shift the dose to the evening instead of making that morning med pass so very heavy? So just looking at that, seeing what the resident really wanted. And, you know, at the end of the day, from a facility perspective, sometimes these shifts actually help unload the morning med pass and can make your staffing a little bit easier as well. So talking about exceptions, we talked about a couple there, like Fosamax or Boniva, that there really is an exception to that you would have to address in your resident-centered plan of care. There are some medications that should be taken with food. We talked about the insulin. Some of the shorter-acting insulins are supposed to be given right around food time. And this list are some of the other medications that really should be taken with food in order to get the best possible effect. So looking at things like carbamazepine, NSAIDs, certainly you're giving them with food to prevent stomach upset. There may be different reasons you're giving them with food, but you know, before you start messing around with these med pass times too much and moving them away from food, you really need to understand why they're being taken with food, because we don't certainly want to cause resident harm by messing with those too much. And then finally, here is a list of meds that should be on an empty stomach. So again, whether that's an empty stomach first thing in the morning, in some cases it can be an empty stomach maybe before dinner. There's some flexibility you have in what time of day the stomach is empty, but do note that if you start shifting around these meds listed here, that they are best on an empty stomach for absorption. So, you know, after you've picked out maybe some drugs that you want to address and you've figured out your resident care plans for managing that, the other piece that you can't forget is the documentation. Because at the end of the day, you will probably be doing some things that are not the standard. If you're moving your Synthroids away from the early morning and maybe putting them before bedtime, that is kind of a little off from what the standard is, and you have to have a rationale for why you're doing that. So what you see on the screen here is what we did with one facility, is we created an optimization worksheet. So we took several of the drugs, and we wrote basically disclaimer statements for the physician to sign off on. So we have some wording here that the physician understands that, you know, the manufacturer may recommend that we give it first thing in the morning, but for resident-centered care purposes, or however you want to word it, we have chosen to do it in the evening, and I have looked at the risk versus benefits of this, and I agree that it's okay to do. And basically, the physician would sign off on that or a similar statement, and then this would be part of the medical record for the patient. So in the event that you do get questioned on survey or by someone, you would have a documentation of a risk versus benefit for these facility-wide decisions that you're making for some of these meds. So I know we are about out of time, and I know we wanted to have some time for questions. So that was actually the end of my pharmacy-specific piece of this, and I think we were going to open up the line for any specific questions that anyone may have.
Yes, thank you, Jennifer and Bill. This is Linda. Emily, would you please at this time post the evaluation questions? And Laura, if you would please open the lines for questions and remind the attendees how to ask the questions.
Certainly. The floor is now open for questions. If you do have a question, please press the number 7 or the letter Q on your telephone keypad. Questions will be taken in the order they were received, and if at any point your question has been answered, you press 7 or Q again to disable your request. Our first question comes from Bonnie Zamora. Bonnie, please go ahead.
Okay, it's Connie, but that's okay. I would just like to, I'm interested in maybe a specific example of best practice strategy maybe that a nursing home that you know of has utilized to get to the point where they can start implementing these varied medication pastimes that are more in tune with the resident, being resident directed. So I was just interested in some of the strategies that they use to move toward that way of thinking.
Jen, you want to take that one?
Sure, yeah. So I think I've seen it attacked a couple different ways. We've had some organizations that they have truly embraced across the entire organization and to a very deep depth culture change. So you've seen things like, resident rooms around a central living area, cooking meals in the central room. So they're really, functionally really trying to look at a resident-centered model. And in the medication task, they had a huge level of dedication to sitting down with the prescribers and the nurses and the pharmacists, and they sat down and went through patient by patient and made med-pass time changes and things like that. So it was really a full-on resident-centered care culture change that the entire organization was going about. And that took a lot of time. So that, I think, is a little more on the rare side from what I've seen. Kind of on the other side of the spectrum, I've seen facilities trying to implement some of the smaller changes here, especially around early morning and late night medications, as well as the number of med passes for an individual patient throughout the day. So they're trying to kind of simplify med regimens, trying to stay away from the very early morning and the very late evening, unless the resident, of course, is up in the very early morning or in the very late evening, and trying to just kind of make smaller changes there to improve some of those aspects. So it's really a spectrum that I've seen, and it determines by how much time and effort and buy-in from the other individuals in the organization as to how deep you can go with this.
Well, thank you very much.
Our next question comes from Bob Connolly. Bob, please go ahead.
Hi, my name is Bob Conley, and I work at CMS in Quality, and I'm a social worker in Maryland. And as I was listening to your presentation, I was thinking of how CMS has put this big emphasis to reduce antipsychotics and sent out manuals with videos and a lot of very good stuff that Karen Chamberlain, who's on our Culture Change group, has set up. So there's this whole emphasis naturally on how do you reduce antipsychotics, use non-behavioral, and I think all the principles that you described in terms of patient-centered care and resident voice and everything and surrogate's voice come into it. I guess I just wonder from a survey point of view and from a pharmacist point of view how that multidisciplinary care is being handled, in terms of whether an antipsychotic is really needed in a dementia patient or not, or whether they're following good pharmacological guidelines.
If you want to take a swipe at the regulatory piece, you have a pharmacy piece. I can tell you that we review a lot of nationwide deficiencies, and I think survey agencies look long and hard at the process of medication management now. And so it is not unusual at all to find facilities being cited for process issues around antipsychotics. Again, at the end of the day, there's not a prohibition against using them for behavioral related dementia issues, but there is a lot of burden placed on the process. So, and quite frankly, as Jen alluded to in much further discussion, the concepts in F329 are really sound clinical concepts. And in my whole career, medication has been a survey priority in Maryland, I know, and in many other states. So while the survey piece of it is just one area of impact on medication management and antipsychotics, I think it's been fairly well vetted at this point. And again, I think if you like antipsychotics, wait to see what happens with antibiotics. I think that's the next big one. Go ahead, Jen.
Yeah, thanks. I really think that some of the practices that we get to that end up being very sloppy are because people run out of time. And I think the antipsychotic initiative and the focus and priority on it, just like so many priorities before it, make us as healthcare providers focus on that issue, we spend more time on it. And I think the same is true with medication management. I think you kind of get medications going, a pill will solve that. It's very easy instead of having to go to therapy or make large changes to diet or spending more time with a patient. A pill is much easier, and everyone's so busy trying to manage everything that I think we tend to get sloppy, and I can put myself into that category. So I think, these initiatives put more focus. Therefore, you can have more time and energy and attention to those issues, and we can solve them. I think we're making great headway on antipsychotics, but it takes time, which equals money. And I think that's where really the challenge is that we have, because while you're putting a finger in the dam over here with antipsychotics, then you're taking a finger out of something else. And that's really the balance that we all struggle with, and sometimes we're just on autopilot, and that autopilot, unfortunately, is not necessarily the best thing for our patients. So I think it's taking the resources and refocusing them on what's important to the patient is really what we're looking at with this management piece.
Jen, I'll just quickly follow up in that, society-wide, we think a pill cures everything, and we often demand of either overtly or covertly of our healthcare providers to treat us with medications. That doesn't change when we walk into nursing homes. So there's accountability across the board on how medications are used and if they're used. And sometimes I know prescribers are pressured by residents or families or even the nursing staff at the building to do something, and that something is often a pill. And that's a culture of thinking that is changing but has a way to go.
Thank you.
This is Linda. I know that we are 2 minutes after 3. We do have one question in chat. If we could just take 1 or 2 minutes just to address that briefly. And that question is, please address privacy issues when administering drugs during meals. Bill or Jennifer?
I'll give it a shot, Jen. So, privacy issues in administering drugs. So, does giving a pill to somebody have to be a sterile event where no one can witness it? I don't think that's the current standard. I think that, I'll be obvious with it. If you're going to give somebody a suppository, it's probably not best done in the middle of the dining room. Certainly that's not what you meant, but I think that the act of giving medications is not in and of itself necessarily a privacy issue. On the other hand, the devil's always in the details. If you have a resident who was particularly concerned about other people knowing what medicine she was taking, or if she was taking at all, I could certainly see times and places where individual residents would prefer to have their medications given not in public.
Okay, thank you, Bill. I believe that we are out of time. I want to thank Bill and Jennifer. This has been a wonderful presentation. And I want to thank everyone who has participated in the webinar today. Please take a moment to complete the evaluation questions, which are found on the right-hand side of your screen. And please remember that if you are requesting NAM credits or CEUs, completing the evaluation is required. Thank you, everyone, and have a great afternoon.
Thank you.
Thank you. This does conclude today's teleconference. We thank you for your participation. You may disconnect your line